Acquired myopathies are muscle disorders that develop after birth due to external factors. They can arise from medications, autoimmune processes, endocrine abnormalities, or systemic illnesses. Unlike congenital myopathies, they can affect anyone at any age and are often reversible. Inflammatory myopathies like polymyositis and drug-induced myopathies are common examples. Lab tests like creatine kinase and erythrocyte sedimentation rate are important for narrowing differential diagnoses, together with clinical features. Elevated CK indicates muscle injury, while elevated ESR helps differentiate inflammatory from non-inflammatory myopathies. Identifying the underlying cause is key to effective treatment and recovery. Welcome to QuickM with Dr. Aid. This presentation focuses on differential diagnosis of acquired myopathy for educational purposes. This slide outlines the differential diagnosis of commonly tested acquired myopathies. Key disorders include glucocorticoid-induced myopathy, polymyalgia rheumatica, inflammatory myopathies, statin-induced myopathy, and hypothyroid myopathy. Each condition is characterized by specific clinical features, ESR, and CK levels. Mnemonics can aid in remembering key features of myopathies. This slide introduces two high-yield mnemonics: HIS CreaK for conditions that raise creatine kinase, CK, and PIE gets inflamed for those elevating erythrocyte sedimentation rate, ESR. For elevated CK, use HIS CreaK, hypothyroid, inflammatory, statin-induced myopathies, CK elevated, all of which involve direct muscle fiber injury, leading to CK release. For elevated ESR, PIE gets inflamed. Polymyalgia, inflammatory myopathies, elevates ESR. Due to systemic inflammation, these mnemonics provide a quick, memorable framework for differentiating lab patterns. Inflammatory myopathies are unique in having both elevated CK and ESR. Remember this with the I in both HIS and PIE mnemonics. This dual lab elevation is a key diagnostic clue, particularly when working through a differential of proximal muscle weakness. Note that differentiation from non-inflammatory myopathies is best achieved through muscle biopsy, revealing inflammatory infiltrates. Glucocorticoid-induced myopathy presents with normal CK and ESR levels. It is characterized by proximal muscle weakness and atrophy, typically without pain. This condition is distinguished by normal lab findings, despite clinical symptoms. Next, we will look at these high-yield myopathies in details. Glucocorticoid-induced myopathy results from prolonged steroid use, leading to muscle protein catabolism. This condition typically affects patients receiving chronic corticosteroid therapy, such as those with asthma, autoimmune disease, or post-transplant. Clinically, it presents as painless proximal muscle weakness, especially in lower limbs. Unlike other myopathies, this condition results from atrophy of type 2 muscle fibers due to catabolic effects of steroids, without overt muscle necrosis or inflammation. CK and ESR are usually normal. It is a diagnosis of exclusion supported by clinical context. Management involves tapering steroids and possibly physical therapy. Polymyalgia rheumatica, or PMR, affects patients over 50 and presents with morning stiffness and aching of the shoulders, neck, and hips. Despite prominent symptoms, muscle strength is preserved and CK is normal, distinguishing it from true myopathy. However, ESR is significantly elevated, reflecting systemic inflammation. PMR responds rapidly to low-dose corticosteroids, and its recognition is critical to avoid unnecessary workup or immunosuppression. Importantly, PMR is associated with giant cell arteritis, which must be ruled out in patients with visual symptoms or headache. Inflammatory myopathies, such as polymyositis and dermatomyositis, are autoimmune conditions. These autoimmune myopathies are characterized by symmetrical proximal muscle weakness, elevated CK and ESR, and histological evidence of muscle fiber inflammation. Polymyositis shows endomysial CD8 positive T-cell infiltration. Dermatomyositis features perimysial inflammation with perifascicular atrophy and a heliotrope rash or Gautron's papules. Autoantibodies like anti-MI2, anti-Jo1 aid diagnosis, and treatment involves immunosuppressants. Dermatomyositis also raises concern for underlying malignancy, especially in adults. Immune-mediated necrotizing myopathy, or IMNM, is an aggressive, statin-associated inflammatory myopathy distinguished by very high CK levels. Muscle biopsy shows necrotic muscle fibers with minimal inflammation on biopsy, in contrast with other inflammatory myopathies with prominent inflammation. It is often associated with anti-3-hydroxy-3 methylglutaryl coenzyme A reductase. Although inflammatory by classification, it behaves more like a necrotizing process. Unlike self-limited statin myopathy, IMNM does not resolve with statin discontinuation and requires high-dose steroids and immunosuppressive therapy. Early recognition is essential to prevent irreversible muscle damage. Statin myopathy spans a spectrum from mild myalgia with normal CK to severe rhabdomyolysis. Risk factors include high statin dose, lipophilic statins, concomitant CYP3A4 inhibitors, and genetic predispositions like SLCO1B1 variants. CK is often elevated, but ESR is typically normal. Management includes statin discontinuation, switching to a hydrophilic agent like pravastatin or rosuvastatin, or using non-statin lipid-lowering agents if necessary. Hypothyroidism may cause proximal muscle weakness, myalgia, and cramps, often mimicking polymyositis. Laboratory findings typically reveal elevated CK, normal ESR, and abnormal thyroid function tests of high TSH and low free T4. It may present subtly or as Hoffman syndrome, a condition characterized by pseudohypertrophy in severe cases. Unlike autoimmune myopathies, thyroid hormone replacement leads to resolution of symptoms, making this a treatable mimicker. Management involves thyroid hormone replacement, which gradually improves symptoms. Next, we will look at board-style clinical questions for each type of myopathy covered. These questions are ideal for board exam preparation. A 70-year-old man on chronic prednisone for COPD presents with proximal leg weakness. He denies pain. CK and ESR are normal. What is the most likely cause? Answer: the most likely diagnosis is glucocorticoid-induced myopathy. Which muscle group is typically more affected in glucocorticoid-induced myopathy? Answer: the lower extremities, especially the proximal muscles of the legs, are more affected. What is the primary mechanism of muscle weakness in glucocorticoid-induced myopathy? Answer: the mechanism is steroid-induced protein catabolism, which leads to myofibril atrophy, particularly of type 2 muscle fibers. Which of the following lab findings best distinguishes glucocorticoid myopathy from polymyositis? Answer: a normal creatine kinase, CK level, helps distinguish glucocorticoid-induced myopathy from polymyositis, which typically presents with elevated CK. What is the best initial management approach for glucocorticoid-induced myopathy? Answer: the best approach is to taper steroids, if clinically feasible, and consider alternate immunosuppressive strategies if needed. Key teaching. Pearl. Always consider glucocorticoid-induced myopathy in patients on chronic steroids who develop painless proximal weakness with normal labs. Recognizing this prevents unnecessary testing and avoids misdiagnosis. Next, clinical case. A 68-year-old woman presents with morning stiffness in the shoulders and hips. ESR is 80, CK is normal. What is the most likely diagnosis? Answer: polymyalgia rheumatica, or PMR. What is the most characteristic feature distinguishing PMR from inflammatory myositis? Answer: normal CK. Which of the following is the expected response to low-dose prednisone in PMR? Answer: rapid and dramatic improvement in symptoms. What is a potentially associated vasculitic complication of PMR? Answer: giant cell arteritis. A patient with PMR presents with new onset headache and vision changes. What is the next best step? Answer: start high-dose corticosteroids immediately for giant cell arteritis. Next clinical case. A 45-year-old woman presents with difficulty rising from a chair and skin rash over her knuckles. ESR and CK are elevated. What is the likely diagnosis? Answer is dermatomyositis. What autoantibody is most associated with dermatomyositis? Answer: anti-Jo1. Which malignancies are commonly associated with dermatomyositis? Answer: ovarian, lung, pancreatic, stomach, colorectal, and lymphoma. How does inclusion body myositis differ from other inflammatory myopathies? Answer: it is characterized by symmetric distal and proximal muscle weakness, dysphagia due to cricopharyngeal involvement, endomysial inflammation, rimmed vacuoles, and cytoplasmic inclusion bodies on biopsy, and most importantly, it is typically refractory to immunosuppressive therapy. Next clinical case. A patient taking simvastatin reports new onset muscle pain. CK is elevated. ESR is normal. What is the likely cause? Answer is statin-induced myopathy. What is the next best step in management of suspected statin-induced myopathy? Answer is discontinuing the statin is the next step. Simvastatin and atorvastatin are more likely to cause myopathy due to higher lipophilicity. Next clinical case. A 55-year-old patient presents with rapidly progressive proximal muscle weakness and extremely high CK above 10,000 units per liter. What is the most likely diagnosis? Answer is immune-mediated necrotizing myopathy. What antibodies are commonly associated with this condition? Anti-SRP and anti-HMG-CoA reductase antibodies. What is the hallmark muscle biopsy finding? Answer is myofiber necrosis with minimal inflammatory infiltrate. What is the typical clinical response to statin withdrawal? Answer is often requires immunosuppressive therapy even after stopping statins. Next clinical case. A 55-year-old man presents with fatigue, muscle cramps, and weight gain. CK is elevated, ESR is normal, TSH is 45. What is the diagnosis? Answer: hypothyroid myopathy. What neuromuscular sign may be present on exam in hypothyroid myopathy? Answer: delayed relaxation of deep tendon reflexes. Which laboratory pattern is typical in hypothyroid myopathy? Answer: elevated CK, normal ESR. What is the definitive treatment for hypothyroid myopathy? Answer: levothyroxine replacement. What rare complication can occur in severe hypothyroid myopathy? Answer: rhabdomyolysis. Other less commonly tested myopathies include hyperthyroid, critical illness, infectious, and alcoholic myopathies. Each has distinct causes, clinical features, and treatment approaches, emphasizing the diversity of acquired myopathies. You may pause the video to study this table. For bonus high-yield content, critical illness myopathy involves muscle fiber dysfunction, while critical illness polyneuropathy involves axonal neuropathy. Key differences include sensory involvement and reflexes, with CIP showing sensory loss and reduced reflexes. If you learned from this video, please like, share, and subscribe.